So in terms of adult disorders, one of the other common disorders that we see is voice disorders. Voice disorder refers to a condition in which the voice functioning is unacceptable to the user. So for example, if somebody walks into your clinic and they tell you, look, I'm a singer, I can hit my high notes, I've been able to do that so far, I had an upper respiratory infection, since then my voice is not usually the way it is, but to you their voice still may be sounding near normal, which is like the cultural norm of acceptance, near normal. But if they think that the voice functioning is unacceptable in their social, professional, or other context, and for which you find some corroborative evidence, maybe they have muscle tension dysphonia, maybe they have laryngitis, which is the reason why they are not able to hit their high notes, or maybe over a period of time they developed a lesion on their vocal folds, which prevents them from reaching their high notes. So a voice disorder is defined as something that is not acceptable to the user. So for example, if I speak like this with this rough, raspy voice, and if I constantly kept speaking like that with a rough, raspy voice, that becomes one of an example of a voice disorder. Or if somebody is speaking like this with a lot of breathiness in their voice and they're not able to sustain a lot of breath, then that becomes a breathy voice, right? So these are some things that I'm just giving you a few examples. These necessarily are not textbook kind of cases. There will be a lot of individual differences when you talk about voice disorders, okay? But a basic thing. So voice disorders is if there is a rough voice, if there's a hoarse voice, a breathy voice, there is a strain to produce your voice. I'm gonna produce my voice like this. It's a really strained quality of voice, right? Excuse me. So those are some of the things that comes under voice disorder. When we talk about voice disorder, the assessment components include a very detailed case history. You want to know when the problem started, that is the onset, whether the onset was sudden, whether the onset was gradual, was there any contributing factors or precipitating factors surrounding those onset, okay? Then you want to know about their hygiene, how much water they drink, if they have acid reflux, and the way they kind of use their voice. Does it require for them, what is their occupation? Does it require for them to use their voice quite frequently? Okay, so a lot of things goes under the case history component. Then we want to know how much effort does somebody need to produce their voice. Like we all take this for granted. I know you're sitting there, I'm like, yeah, effort to produce voice, what does that mean? As people that usually produce their voice, we take it for granted as how much a voice disorder can have an impact on life or regular functioning. Okay, so phonatory effort is the effort that is required to sustain or produce phonation. Okay. And typically, in individuals with voice disorders, that is usually the effort to produce voice is increased. There are something called self-perceptual measures. In terms of self-perceptual, meaning you give certain self-perceptual rating scales to individuals and ask them to rate how much does their voice functioning. So it's basically like a self-perceptual quality of life survey. How much does the voice disorder impact their life? Auditory perceptual, a very key component of voice disorder, is you listen to their voice and you rate their sample based on different parameters. Okay. Then you do something called acoustic analysis. Acoustics is nothing but the study of sound, right? So you want to know the study of their voice that becomes acoustics. You're looking at fundamental frequency, intensity, pitch range, intensity range, noise to harmonic ratio, things like that. Aerodynamic analysis is basically measuring the physiological measures, their subglottic pressure, their airflow, okay? And then the key thing is, once you've done all this as a speech language pathologist, the first few things, except the visual perception analysis, everything else is done by a speech language pathologist. In some states, visual perception analysis can also be done by a speech language pathologist, but speech language pathologists cannot give a diagnosis. Only an MD can give a medical diagnosis, okay? So visual perception analysis is something where you take a look at the vocal folds. There are different ways to look at the vocal fold. You can either go in through the nose, called a nasoflexible stroboscopy, or you can go through the mouth, which is called an endoscopy, a rigid endoscope. And you look at the vocal folds to make sure that there are no lumps or bumps on the vocal fold. Both vocal folds are moving symmetrically. If there is a paralysis of one vocal fold might not move. And are there anything else, signs of acid reflux on the vocal folds? So this will give us an idea of what the underlying condition is that is resulting in all of these voice problems that the individual is facing. Okay, so let's go a little bit more into detail. I gave you a brief overview. As I said, self-perceptual measure is a measure that is given to the individual, to the person that comes to you with a voice problem, and we ask them to fill out that survey or the rating scale. And once we fill out the survey or the rating scale, we go in and see how much does a voice disorder impact their life. So for example, I'm going to pull up a rating scale that's here, the VHI-10. Okay. The VHI-10 here, if you look at it, let me see if I can zoom it. Yeah, there we go. The VHI-10 says, these are statements that many people have used to describe their voices and the effects of their voices on their lives. Okay, circle the response that indicates how frequently you have the same experience. So 0 is never, you anchor them, 0 is never, 4 is always, and then 1 is almost never, 2 is sometimes, 3 is almost always. Some of the questions, that is, my voice makes it difficult for people to hear me. I feel left out of conversations because of my voice. My voice problem causes me to lose income. People ask, what's wrong with your voice? The clarity of my voice is unpredictable. My voice makes me feel handicapped. I feel as I have to strain to produce voice. These are some things from an individual perspective. How much does a voice problem pose difficulty? Okay, this is a quality of life questionnaire. So you get numbers on this. These can serve various purposes. First purpose is to know what's going on with their voice, right? You want to know how much their voice disorder has an impact. 2, you can get pre and post measures. So you get a person that comes to your clinic, you get this before treatment, you provide them with treatment, so you have a baseline, and then you compare after treatment, you give the exact same questionnaire and see if treatment has had an impact on their quality of life, or how much the voice disorder has an impact on their life. Okay? So these are some things that we use as part of an assessment. I will also make sure that you receive a copy of this. I'll send it to Ms. Rice and ask her to post it on your D2L, so you have a copy of that. Another one is called the auditory perceptual measure. There is a form that's called the KP. It's called a consensus auditory perceptual evaluation. Again, let me repeat. KP is nothing but consensus auditory perceptual evaluation form. In a KP, what you do is there are ratings. There are certain parameters that you will rate your individual's voice on. So somebody goes, ah. You hear how kind of rough that voice was? It had some strain to it. So the attributes on KP are overall severity, the roughness, the breathiness, strain, pitch, and loudness. Okay. I'm going to pause here for a second. I'm going to pull up the KP rating form. Let's see. Bear with me. You're going to see a little bit of my desktop and everything. But I will pull up the KP rating form so you can see that. There we go. Okay. It makes more sense if I showed you this rather than just talking on it. So as you see, some of the parameters that we rate on are overall severity, roughness, breathiness, strain, pitch, and loudness. What you see here is a visual analog scale. This line that it actually measures 100 millimeter. What you see here is mild, moderate, and severe. Those are the severity of the voice that you can rate on each of those parameters. The C and I here say it's consistent and intermittent, whether the parameter that you're observing in a person's voice, is it consistent or is it intermittent? And then once you put a line, say for example, I perceive somebody's roughness as moderate and I put a line here on that, you take a ruler, you measure that where the line was placed and you put the number right here on the screen. Okay. So you ask them to read, you ask them to sustain vowels R and E for 3 seconds, 3 to 5 seconds. You ask them to read these 6 sentences right here. The blue spot is on the key again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins and Peter will keep at the beak. And then you get a spontaneous speech sample. After you listen to all of those stimuli that you have presented to them, you rate them on these parameters. In pitch, you want to indicate whether it's a low pitch or a high pitch. In loudness, you want to indicate whether it's soft or loud. And some of the other parameters, additional parameters, are listed here. Okay, so auditory perceptual measure is a very, very important measure in terms of rating somebody's voice. Is it deviant? How much is it deviant? Okay, and what parameters makes their voice deviant? That's an auditory perceptual measure. Okay, then we have acoustical analysis. Basically, in acoustic analysis, I want to know what their fundamental frequency is. Fundamental frequency, if you've taken my speech science class, is defined as the lowest component frequency with which our vocal folds vibrate easily. Basically, number of cycles per second. And for men, is about 100 to 110 cycles per second, and for females, it's 200 to 220 cycles per second. Frequency is measured in hertz. Okay. You want to know what their frequency is and what their range is. Can they go, how low can they go, and how high they can go in pitch. If somebody has a lesion on the vocal fold, why is this important? If somebody has a lesion on the vocal fold, there is more mass on that vocal fold because of the lesion. If there is more mass, your frequency, fundamental frequency, is going to decrease. And when they actually try to produce a high pitch range, because of the stretching of the vocal folds and the stretching of the mass across the length of the vocal folds, their voice is going to crack. Intensity is how loud somebody is. It's measured in decibels. You want to make sure that they are using a right intensity of voice, whether it's too soft in loudness or too loud in loudness. If somebody has a vocal fold paralysis or atrophy of the vocal folds, meaning as they get older, the vocal folds lose tonicity and they're not able to bring their vocal folds completely to midline together because of the loss of tonicity, then your intensity goes down. So those are some things that you will be looking for when you're looking at a voice person. If you've again taken my speech science course, you know what airflow and subglottic pressure is. When we use our voice for phonation, we need to build sufficient subglottic pressure to open the vocal folds, right? The minimum subglottic pressure required to initiate phonation is 3 to 5 centimeters of water. The minimum subglottic pressure required to sustain phonation is 5 to 7 centimeters of water. That is what you're going to measure as subglottic pressure. Airflow is once you build the pressure and the pressure exceeds the pressure above the vocal folds, you're going to blow open the vocal folds and the pressure is going to flow as air between the vocal folds. There is an average airflow that flows between the vocal folds. It's 100 to 200 cubic centimeters cc per second, or 100 to 200 milliliters per second. So when you're talking about airflow and subglottic pressure, what does it give us? If you're using more pressure to drive your vocal folds, which means it's going to be more effortful to produce your voice, you need to have sufficient airflow between your vocal folds. If you're not using regular airflow, then there's going to be less airflow between your vocal folds. Now, I'm providing you with a very brief overview here. This is not something that I wanted to actually cover in 10 minutes or 15 minutes, but this is something that I want you to understand, that there are different ways to look at different adult disorders. The assessment varies between different adult disorders. Case history becomes a very important component in any adult disorder that you're dealing with. Okay. In voice is a very specialized field, so I'm talking about very specific. And if you have taken my class, if you have had my 2 courses in the fall, you know that my area of specialty is voice disorders. So I want you to know, in terms of voice disorders, that there are ratings that are from the client perspective. There is, you hear their voice and you rate something. Then you get an acoustic analysis, meaning you want to kind of take that voice and divide it into component parts of frequency and intensity, see what the differences are, and then you want to get some physiological measures. All of these might not make sense to you, but when you actually look at a voice disorder, all of these is going to help you put the puzzle pieces together to understand what might be going on with a voice disorder. Okay? All right, so that sums up with voice disorders. The next adult disorder that you might encounter is fluency disorders. Now, fluency disorders can be part of both a child pediatric condition that you'll see in a pediatric clinic, or you can even see in an adult clinic. Okay, stuttering is what comes under fluency disorder. It basically affects speech fluency. Stuttering is characterized by repetitions, prolongations, and silent box. So if somebody came to you and said, my name if they have those blocks or repetitions, then you are characterizing that person to have a fluency disorder, which is stuttering. Most of the times, fluency disorder is developmental. It happens during the normal non-fluency stage, which is between the ages of 3 and 4 years. That is common to develop a fluency disorder. And males have more fluency disorder, incidence of fluency disorder than females. There's a huge genetic influence of having fluency disorders. And sometimes fluency disorder can be acquired as well. There is a neurogenic stuttering that is called, that is part of an acquired, maybe somebody had a stroke or somebody had a TBI and then they started depicting a fluency disorder. So if you had, what are some of the assessments if you had somebody that came into a fluency clinic? What are some of the assessments that you can do? Just as you did with any adult disorder, the client perspective and the impact on quality of life is very important. And when any adult comes to a clinic, the adults have typically had a fairly reasonable, normal functioning life before the onset of a voice problem, before the onset of a stroke, before the onset of a central nervous system disorder. So before having any of those conditions, they had a certain quality of life. So what happens after having that condition, you need to assess how much impact the disorder has on their quality of life. Why is it important? It is important to know how it has an impact on the quality of life. Two, one is you want to know if you can develop your goals to change or to develop a goal that has an impact on changing their quality of life, right? Two, you can know how much they're going to be motivated or how much they're going to be compliant depending on how much impact the disorder has on the quality of life. Okay, so it's very important. And the client's perspective, what if somebody comes to your clinic and say, oh, I have no motivation, I know this is because of my stroke and I've learned to live with it. It's going to impact severely on how you're going to work with this client. You need to build up their self-esteem, you need to increase their motivation. Okay. Client attitude and expectations. It's very important here in terms of any actually adult. What is their attitude towards therapy? What is their attitude towards the disorder? What are their expectations when they come to therapy? Do they want to be able to say, for example, if somebody had a voice disorder and say, I can project my voice, their expectation is when I move out of therapy, I should be able to increase my volume and talk to my classroom. Somebody comes to a fluency disorder, there is no cure for fluency. You need to understand that. If somebody comes to your clinic, you're not going to get rid of their fluency disorder completely and say, oh, I've cured your fluency disorder. You're giving them compensated strategies to help with their fluency disorder. So if their expectation coming into the clinic is like, I want to be cured of my fluency problem, then you have a little bit of counseling to do. You have a little bit of literature to share with them saying, these are things that we can offer, these are things that will be the outcome of that, and then you need to talk about it. It's important in terms of a fluency disorder to get a good speech sample and to do observational analysis. So what are these? Let's talk about it. In terms of a speech sample, you want to get a sample size that approximately has 200 to 600 syllables per situation or context. The sample context could either be a reading sample, it could be a conversational or monologue sample, or it could be a telephone call. Typically, why you want all of this is reading is sometimes easier than a conversation or monologue. Telephone call, they have a lot of difficulty. Okay. When you get these samples, you need to record these samples, and you need to transcribe these samples to get how many syllables they spoke, what are the different characteristics that have displayed in their fluency disorder. So the type of fluency analysis would be whether did they repeat a syllable or repeat a word. Did they place any interjections between their sample? Did they prolong a syllable or prolong a word? Or did they have silent blocks? So for example, let me give you an example of repetition, prolongation, and silent block. For example, if somebody goes m, 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 that becomes a repetition. That's a syllable repetition. If somebody goes m, 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 my, that becomes a prolongation. A silent block is completely silent. They go mm, and then they're stuck there in that M position. You can't see my mouth. So when I'm doing a silent block, I'm trying to say the sound M, and I go mm, and then I'm stuck in that position and then go my. When it comes out, that becomes a silent block. An interjection is you're trying to place something between. So my name is James, right? So when you're saying that becomes an interjection. So anytime you record a sample, you get in the context of either a reading or a conversation or a telephonic call. You record that sample, you transcribe that sample, and then you go in and pick the type of fluency type they have, either it's a repetition, interjection, prolongation, or a silent block. Once you do that, you want to calculate the percentage of stuttered words. The number of stuttered words, which could include any of these. If you're not looking at a specific type, you can put all of those under the number of stuttered words, divided by the total number of words that they spoke, times 100 will give you a percentage of stuttered words. Okay. We will see if we can post a sample. I will ask Ms. Rice to see if we can post a small sample, stuttering sample, and you can calculate the percentage of stuttered words for that sample. Okay, so let's take a step back and talk about what we talked in fluency disorders. Fluency disorder is something where it affects the speech fluency. There are different types of characteristics in a fluency disorder. Typically, the types include repetition, interjection, prolongation, or a silent block. There are different ways you need to assess them. The quality of life, impact on the quality of life, what are their expectations and attitudes towards the disorder. Getting a speech sample and doing an observational analysis is very important. For a speech sample, you can get a speech sample in terms of a sample size of 200 to 600 syllables. You can get a conversation, reading, telephone call. You can get one or two or all three of them. You record them and transcribe them. Once you have them, you get the percentage of stuttered words using this formula, right? There is an instrument that's called a stuttering severity instrument, SSI-3, and now they also have an SSI-4, the stuttering severity instrument 4. The stuttering severity instrument calculates your disorder, your severity of stuttering, based on 3 components. What is the frequency of stuttering events? What is the duration of stuttering? What is the intensity of concomitant characteristics? Now, let me say, you know about the frequency of stuttering, right? That's calculated by this percentage of stuttered words. The duration of stuttering, and then the intensity of concomitant characteristics is nothing but associated characteristics in addition to just the speech disfluencies. Some people, let me skip this slide and go to physical concomitants for a second. Some people, when they're trying to say, they could have these associated concomitant characteristics in addition to their disfluent speech. They could have head jerks. They can go, you can't see me. They could have head jerks. They could have their eyes closed, squinting and trying to say the sound. Or they have a hand. Some people will actually, kind of hit their thigh to get a certain sound coming out of their mouth. They could actually move their body to get that sound. They could have jaw tremors, or they could have nostrils flaring. So a lot of these are observational analysis. You look at these physical concomitants. You look at if they are anything when they are making that repetition, when they're making that prolongation, or when they're making that silent block, in addition to their speech being this fluent, are they demonstrating any additional physical concomitant factors? That's what is called the intensity of concomitant characteristics. For this SSI, you need to get 2 sample contexts. One is a spontaneous speech and then a reading sample. A speech sample beyond a clinic setting is encouraged. And once you calculate all of those components based on these 3 characteristics, you could categorize the stuttering to be a very mild, moderate, severe, or very severe stuttering. Okay. So SSI-3, and then they have one of those where we talked about quality of life and impact it has. They have something called the OASIS. It is a self-perceptual rating scale, mostly used in kids more so often than adults. And so these are the things that you look for in a fluency disorder. So fluency disorder is also called stuttering, where the fluency of speech is affected. You're looking for speech disfluencies. The types of disfluencies include repetitions, prolongations, interjections, or silent blocks. Sometimes, in addition to those, you also have some physical concomitant characteristics, which are other body movements in addition to their speech disfluencies. SSI-4 and 3 are one instrument that is used to obtain something. And you can calculate the severity of the type and frequency percentage of stuttered words using this formula. Okay? So that sums up with 2 major things, the voice disorders and fluency disorders. I'm going to take a pause here and then finish up with aphasia.